Thank you very much again. Thanks to the organizer for giving me the opportunity two times. And this time, I'll be speaking on from clinical trials to clinical practice and raising the standard in the hormone receptor positive metastatic breast cancer management. So we will be discussing a little bit data which probably might have missed in the recent meetings, and they'll just highlight those missing data in my this presentation. So if you look at the relatively high overall response rate with CDK4 presentation in the first line, we see that there is an unprecedented response rate of reaching up to 55.53 in Paloma 2 to the second line setting and beyond. The response rate can reach as high as up to 48% in the which we have seen in the Monarch 2 trial. So there is no doubt that this combination of endocrine therapy with CDK4/6 inhibitors are a really very good combination. And beside this, it is very important for us to know at this juncture that these response rates are 11 to 15% higher than the aromatase inhibitor monotherapy. So this tells us very clearly that you need to use a combination of endocrine plus CDK4/6 inhibitor instead of aromatase inhibitor alone in the first line. And this information is also important for all of us that the overall response rate with the single agent chemotherapy in metastatic breast cancer is around 40%. So the answer is very clear that which molecule or which combination we need to use in hormone receptor positive metastatic breast cancer. And when we look at the progression free survival in all these first line trials, you will find that the curves are so very similar to each other. So we know that the drug is all the CDK4/6 inhibitor almost are equi-efficacious, but the curve were almost same with each other because the trial design was in such a was in such a way it was designed that the patient population was almost identical in each of the trial. If by any chance that the patient population is different, then the survivor curve may be different from each other, but that does not draw any conclusion. Basically, these are all very good molecules and is the standard of care these days in combination with the endocrine therapy. And there is a 43% prolongation in the progression-free survival over the endocrine therapy with the absolute difference of nearly 10 months. So the next question is that do we have any other agent beside aromatase inhibitor for hormone receptor positive in the first line setting? So initially the high dose fulvestrant was tried instead of 250 milligram, 500 milligram was attempted, but it showed that the results were only satisfactory in the bone without the visceral disease. And the visceral disease, the curves were overlapping with each other in fulvestrant arm and the anastrozole. So it did not really benefit all the subgroup of these patients. So it took little bit of backseat than the combination arm. Then the next question was that do we have an ideal endocrine partner with the CDK4/6 inhibitor during the first line setting beside aromatase inhibitor? So this question was, we tried to answer this question in a phase 2 very well designed Parsifal trial, which was presented at ESCO 2020. So the goal of this Parsifal trial was to determine the optimal endocrine backbone in combination with the palbociclib in the first line scenario. So in this phase 2 trial, the fulvestrant plus palbociclib was directly compared with the letrozole plus palbociclib, and surprisingly the non-inferiority was not established in this trial, and the subgroup analysis generally consistent with the overall conclusion, and overall survival was also not different between the two arms. So result of this Parsifal trial was inconclusive, and treatment decision should balance the preference of the patient and the clinician and the later treatment studies, because managing hormone receptor positive metastatic breast cancer is a continuum of care these days. So you need to plan your first line therapy very strategically. So how does the result of Parsifal study translate into the clinical practice? So the data are very convincing that the more invasive, less convenient, and potentially more toxic route of using fulvestrant is now not needed in the first line, and patient may welcome a treatment with the simple oral tablet and be safe in the knowledge that it is as good as the fulvestrant. So the message is very clear that an all oral pill combination is the new standard care, and in the patients who are somehow allergic or somehow have other reaction history of reaction to aromatase inhibitor, those are the very small subgroup of the patient where the fulvestrant can be combined with the CDK4/6 inhibitors. So so now the next question, after deciding that the which drug, which endocrine partner should be used in the first line, then the next dilemma in this CDK4/6 inhibitor is the O of overall survival. So it is the most hyped trial is the Paloma 3. So there was a 6.9-month longer overall survival with palbociclib and fulvestrant, but the finding did not reach statistical significance in intention to treat population. While in comparison to the other trial which we use the same combination, Monalisa 3 and the Monarch 2, that there was a clear-cut overall survival advantage. But what we must know that there was not something wrong with the palbociclib. It was the design of the trial. And the palbociclib, the Paloma 3 trial, which used the combination of palbociclib and fulvestrant, it is a very strong suggestion that probably the overall survival benefit would have been statistically significant in this trial if the trial of the Paloma 3 was little bit larger, and the survival could have easily been demonstrated. Because when we look at the progression free survival in the second line setting, using in all the three on all the these three trial, when we compare about the Paloma 3 and the Monarch 2, the difference in the patient population significant was significantly observed, because in the Paloma 3, prior endocrine therapy or one prior chemotherapy was allowed, while in Monarch 2, only one prior endocrine therapy or no chemotherapy was allowed. So this was the uh, basic design of the trial, which resulted in non-statistical significant overall survival in Paloma 3. So, but if we dissect the data of Paloma 3, what happened to the endocrine sensitive population versus the endocrine insensitive population. So, if you look at the endocrine sensitive population, if we had put all the patients of endocrine sensitive in Paloma 3 also, we could have achieved the overall survival of nearly 40% with the hazard ratio of 0.72%. So, this was the main highlight I wanted to pinpoint when we consider the dilemma of overall survival in Paloma 3. And the same issue with the premenopausal patient, we can use any of the CDK4/6 inhibitor. You need to convert the premenopausal patient by using the GNR analog or the surgical oophorectomy, and then treat them as the postmenopausal patient. And you can see that if we adopt this strategy, the survival curves are so very similar to each other. So in it, the all these three molecules work beautifully in the premenopausal patient once we convert them into postmenopausal patient. The another highlight of the Paloma 3 trial, that irrespective of the baseline ESR1 mutation status or the PIK3CA mutation status, the, this molecule worked very well, and you can see the very impressive hazard ratio. So this was not a deterrent in using the palbociclib in this group of the patients. So this was the another highlight of Paloma 3, beside artificially created no difference in the overall survival versus its limited usefulness in the premenopausal patient. So this this molecule palbociclib work equally in all these subgroup of the patients. So basically, what I want to highlight the point is, when you need to compare the apples, you need to compare with the apples, not with the oranges. And if the issue of overall survival and the efficacy in the premenopausal patients were really big, then probably this molecule wouldn't have find a place in the NCCN's recent version 62020, where all the molecules have been given the category 1 recommendation. So this speaks of this molecule, that this is as good as the other molecule available in the market. So ABC 52020 guideline informs us that the CDK4/6 inhibitor, when combined with the endocrine therapy, is the standard of care in patients with hormone receptor positive, HER2 negative advanced breast cancer, since it achieves a substantial progression-free survival benefit, significantly increase overall survival, and may or may not maintain the though improved quality of life. The CDK4/6 inhibitor can be combined with aromatase inhibitor or with fulvestrant as per the Parsifal data in the de novo or the recurrent advanced breast cancer in the first or second line, and in case of primary or the secondary resistance. It will, in both the setting, this molecule will work in the equal manner. So this recommendation applies to the postmenopausal woman, to premenopausal woman in combination with the LHRH agonist, and to men also who are hormone receptor positive metastatic breast cancer, but in combination with the LHRH agonist. And this was given a category 1A, and 97% of the panelists in ABC5 agreed with these recommendations. So again, if we talk in terms of the ISMO MCBS scoring, which is a very robust parameter to assess the efficacy of any molecule. So all these three CDK4/6 inhibitor were given the ISMO MCBS score of 3. So it, and the 100% of the panelists who attended this meeting agreed that these molecules are almost same, and each can be used interchangeably. So this was the what I have discussed is the trial data. So now equally important these days is that we need to discuss the real world data which complement the trial world data, and what I will highlight some point which will enumerate the clinical significance of the real world data. So what is the basic difference in the real world data versus the randomized or between the randomized control trial? So real world data is a non-interventional or observational, and it is a usual care clinical practice all over the globe. And the outcome in the real world data is the effectiveness and economic assessment. And the population in the real world data is basically and wide, unrestricted, and few exclusion are there, and comparator is not there in the real world data, and randomization and blinding is also not there in the real world data. Relevance is only for the clinical practice, because not the stringent criteria, the clinical trials have so many stringent criteria that not all patients can be put on the clinical trial. But at the same time, if we assess the efficacy of any regimen or any molecule, then real world data becomes as important as the clinical trial data. So real world data, we have Flatiron data, Polaris data, Iris data, patient assistance program of the various these molecule. We have Indian data which was presented in ASCO 2020 by the Amit Rotan group, and we also have very robust real world data from Rajiv Gandhi Cancer Institute and BL Kapoor also. So people are gradually realizing the importance and clinical significance of real world data, that it cannot be ignored, and it should be given the importance as good as the clinical trial data. So as I have enumerated that the randomized clinical trial have different features than the real world data, and they basically the real world data complement the data from the clinical trial. And the real world data which do not randomize patient, and bias may be introduced by prescribing pattern and the lack of uniform assessment, which eventually become the doubtful causal interpretation. So what is the new method is that you don't take all the patients, all comers in the real world data, but what do we do is that we select the same patient in both the arms which were treated in a very identical manner. So this is called the propensity score matching. So suppose if we have treated the 1,000 patients, those were the all comers, out of which we will select 200 patients which were managed absolutely identically, so that we can draw some inference or draw some observation from the propensity score matching. So this is a new terminology, side by side the real world data, which can give us some unanswered, which can answer some of the questions which were not answered in the clinical trial data. So Flatiron network, as I enumerated, that this was a retrospective analysis of electronic health record from the Flatiron Health longitudinal database in the United States of America by the community physicians of 1,416 HER2 positive metastatic breast cancer treated by the first line palbociclib letrozole versus the letrozole. Of the 1,416 eligible patients, 906 patients were 1 is to 1 propensity score matched to balance the characteristic, and that eventually were the 453 for each cohort. And the median age of this patient in this was the 68.0 and 49, nearly 50% patient had visceral disease. The real world progression free survival, it was a month from the start of palbociclib plus letrozole or letrozole to death or the disease progression based on the clinical assessment or evidence by the radiological scan or the tissue biopsy. So this was the Flatiron study where the total population was 772 in the combination arm, out of which we took out the 464 patient, and letrozole alone arm there were 650 patient and we took out the 464. So exactly balancing, the number of the patients. And if we see the patient characteristics in both the group, they were also almost matching the each other, like we see in the clinical trial data. So the patient characteristic which were well balanced in the propensity score matched cohort, and compared to Paloma 2, older population, more bone only disease, less endocrinal sensitive disease, and less visceral disease were also included in the this trial. And this is the Flatiron study, real world progression free survival, and these are the unmatched analysis for the all comer patients. And you can see that even this also there is a clear cut benefit in the unadjusted analysis of progression free survival as well as the unadjusted analysis in the overall survival. But after the propensity score matching is adjusted analysis in the progression free survival and overall survival, you can see that the separation of the curve very early in the course of the treatment, and the overall survival which was questioned in the trial data was very well evident in the propensity score matching when we took the real world data out. So it was 2 year overall survival of palbo plus letrozole versus letrozole alone was finally came out to be 80% versus 63%. So this was a clear cut evidence that there is an overall survival advantage with palbociclib and letrozole as well as we have seen with the other molecule in the trial data. So very impressive overall survival data both for the letrozole and but much better with the combination of letrozole plus palbociclib. And this is the forest plot curve, which is telling you the same story that the patient who were put on palbociclib plus letrozole were benefited across all groups, and there is only one group or other that were not benefited. But if you clearly see the forest plot curve, the all the patient group were enormously benefited using the combination of palbociclib and the CDK4/6 inhibitor. So the final take-home message from the real-world data using the propensity score matching is that letrozole and palbo combination remains the standard first-line treatment, and the fulvestrant plus palbo doesn't seem to be a better option. The main message from the real-world data is that the magnitude of superior efficacy with the first-line palbo and letrozole over the letrozole monotherapy is achievable in the real-world practice when treating a more heterogeneous expanded population, while the toxicity are within the range seen in the pivotal trial or the clinical trials. And this is the Flatiron was the first comparative effective analysis of palbociclib plus aromatase inhibitor therapy with aromatase inhibitor therapy alone from a large cohort of the patient in routine clinical practice in the United States. In the real world setting, the first line palbociclib plus letrozole is more effective than letrozole alone in a heterogeneous population and among various patient subgroup. And after the propensity match scoring, the progression free survival with a hazard ratio of 0.4 while the overall hazard ratio for overall survival was 0.58, as we have appreciated in the clinical trial data. So the real world data really complement the superior clinical efficacy observed with the CDK4/6 inhibitor in the randomized clinical trial, supporting the use of palbo in combination with aromatase inhibitor as a standard of care for first line treatment of patient with hormone receptor positive and HER2 negative metastatic breast cancer. Although median overall survival was reached in the letrozole alone group also, as I have shown you in the survival curve, the significant censoring in the overall survival analysis highlights that the we need a longer follow-up, and the overall survival in the combination group will become more appreciable then. So choosing wisely in 2021, which CDK4/6 eventually will you choose? So the one thing which intrigued me very much was that because we are using these drugs in the first line setting, so the patient has to take these drugs for a longer period of the time, and these are, you know, good number of the patient are premenopausal patient with some or the other kind of comorbidities. So what becomes important is the major drug interactions. While the data from the palbociclib and amoebacyclib are quite identical, that there were 67 to 68 major drug interactions, while in ribociclib there were 259 major drug interactions. So this really become a matter of concern. So you have all the CDK4/6 inhibitor available to you, and will be available to each and every medical oncologist in 2021. But finally the choice is yours. You should use the best molecule, you should use safest molecule, and you should use the molecule for which the experience is, across the globe, is much wider than the other molecules. Thank you very much for your kind attention.